good evening, everybody. My name is Hong Qiu. I am the Youth Program Chair at AACO, which stands for Asian American Coalition of Ohio. I will be your host tonight, and we are so happy that you can take the time to join us here. So let's get started. We are here tonight to learn something about our hearts, and more specifically, how to treat our hearts well. You might wonder that why we even pick this topic, because AACO's main focus is civic engagement. Recently, I have some personal experience. Several of the people that I know directly or indirectly passed away due to heart issue. And most of them were very unexpected, as they were the typical individual that we consider as healthy and in their middle age. So after the shock subsided, I did some research and found out that cardiovascular disease, commonly known as heart disease, causes every 1 in 5 deaths in the US. So statistics released in January of 2023 by American Heart Association show an increase of 54,000 deaths in 2020 due to heart disease, potentially related to COVID-19, where Asians, Black, and Hispanic people are more vulnerable. So February is American Health Month, a time when all people should focus on their cardiovascular health. And tonight, I want all of you to help me to work on Dr. Lam, one of the best heart doctors in Central Ohio. We are so very fortunate to have Dr. Lam to fit us into his busy schedule. And let me give you a short intro to who is Dr. Lam. So Dr. Lam received his Bachelor's of Science degree at Yale University and his medical degree from the University of Rochester School of Medicine. He performed his internal medicine residency and cardiology fellowship at Duke University, with additional training at the Cleveland Clinic and Harvard's Brigham and Women's Hospital. He has performed research fellowship at the National Institute of Health and the Ohio State University Health and Lung Research Institute. Dr. Lam is currently a cardiologist with Ohio Health in Columbus, where he is the medical director for cardiovascular services in Circleville, and is the founder of the Ohio Health Cardiometabolic Clinic. He is an adjunct assistant professor of medicine at Ohio State University Wexner Medical Center and Ohio University's Heritage College of Medicine. He actually has a lot more credentials, which is just way too long. We're just omit that for now. We are just so happy that he can be here. Dr. Lam, before we get into the heavy lifting, let's start with something that's lighthearted and easy. How's that? Okay, that sounds good. All right. So what kind of pets do you have? Dog, cats, or others? Oh, we have, actually, we are a cat family, mostly because my wife is a crazy cat person. And we have, believe it or not, 4 cats. One of them was they're all strays that we adopted. One of them was a foster kitty that failed, and so we ended up adopting her. But for some reason, all the stray cats in the Dublin community seems to find our house, and we tend to take them in. That's awesome. Thank you for doing that for all the cats. And question number 2, what do you like the most about Ohio? Since you have been here for a while, and especially in winter, why are you here? Well, so actually we're here in Ohio because the job opportunity was great. It's just such a wonderful community. And the thing that I've actually really loved about Ohio was the Asian American community. Gosh, the Asian American community here is so strong. It's such a close-knit group, and they do such great work, addressing health disparities, addressing community service needs, addressing our youth. And I've just been really impressed. I've worked with the Asian American community a lot for, going around the past 7 or 8 years now in a variety of different functions. And so, I just love being a part of this community and helping out in any way that I can. That is awesome. Very heartwarming. Thank you so much. And Dr. Lam, I learned that you just came back from a trip to Belize 2 weeks ago as part of the Partners of Medical Relief. So tell us a little bit about that. Yeah, so so I grew up in Honolulu, Hawaii, and my parents, when we grew up, we actually grew up extremely poor. But one of the things that my family and my parents always taught us was the importance of giving back to community, like local community, but also the bigger picture too. And so when I was, and that's just something that we've always done. And when I was in medical school, I started doing these international medical missions. So going to third world countries to help provide, just a little bit of medical care where we can. And that completely changed my life.
it kind of made me realize everything that we have to be fortunate that we take for granted. It kind of grounds me. It brings me a lot of, it reminds me of grace and compassion. And so when I can, I try to do it. And so I've made a commitment to doing it every year. And so for the past 6 years, I've been going to Belize with a group based out of Cincinnati. And the most wonderful thing about it, though, is that I started to bring my family with me. So my older son has joined me for 4 trips. And this year, my youngest son and my wife was able to join us. And it's just such a great thing to do with the family, just to share that experience. And hopefully they have the same sense of gratitude and humility and compassion that I've been able to gain from it all these years.
Thank you so much. That is such an awesome thing to do for everybody out there. So really, thank you for that. And now I want to give the floor to you for you to give us an overview of the cardiovascular disease, maybe some of the main symptoms and how to prevent that, and what is so especially the special things that we need to look out as Asians.
Sure. Yeah, absolutely. And thank you so much for organizing this. Thank you to everyone in your team for putting this together. Thank you to everyone who's joined. Gosh, I think if I'm reading this correctly, I don't have my readers on, but I think it says 64 people, which is absolutely amazing. And what I want to say was that this is for you, this is for everyone. So what I thought I'd do is just start off with some brief slides, just to sort of, set the ground, the foundation, and then open it up to questions, because I really want to make this really meaningful and really helpful for you. And so I know that some people submitted questions ahead of time, and we'll get to some of those questions. But if anyone has any questions that arise, please feel free to stop me throughout the talk or at the very end. We want to make this very, very good for you. And so let's see, I'm going to share my screen here. Hopefully this works. I'm not the best at IT. Okay, can you guys see my slides here?
That's awesome.
Okay.
Looks good.
Good. One of the things that I'll mention is that I actually do a lot of work in health disparities for the Asian American Pacific Islander community. This is just a big interest of mine. I was a former commissioner on the Ohio Commission of Minority Health, actually appointed by Governor Kasich. And then also I now serve as the chair for the Ohio Institute for Communities of Color, and then also the vice president for the Ohio Asian American Health Coalition. And so I know for a lot of people here, I've worked with you in a variety of different ways in different areas, addressing the health needs of the Asian American community across Ohio. But this has been a really specific interest of mine in the health disparities for Asian Americans. Cardiovascular disease, as Hong mentioned, is a big, big problem. Still, the #1 cause of death in the United States surpasses that of all the cancers combined. But it's estimated, and this is just a rough estimation because our numbers have changed with COVID, but about almost 250,000 Americans each year have heart attacks. Americans each year have heart attacks, and of that, over 600,000 people die each year. And this makes cardiovascular disease a leading cause of death in the United States. The thing that we know, though, is that cardiovascular disease affects ethnicities differently. And the question is how and why. And one thing that I'll tell you is that the data for Asian Americans is actually lacking. And so we don't really have a good understanding of this. We're trying to get a better sense with new research studies that are coming out. I think you all will be hearing in the near future an initiative from the Ohio Asian American Health Coalition for the All of Us study, which actually looks to increase the number of Asian American Pacific Islanders across the country, but specifically also in Ohio, to increase the number of AAPI people enrolled, just so we can get a better understanding of the disaggregated data on how heart disease affects our different ethnic subgroups. And so right now, all of the AAPIs are lumped together in one group. And I'll show you data in just a little bit that that's not necessarily true, right? So Chinese Americans may be different from Filipino Americans, may be different from South Asians, which may be different from Koreans and Japanese. And so we have to have a better understanding of it. But we know, this is actually some of the data that we know. So 5% of Asian Americans have cardiovascular disease. But cardiovascular disease accounts for 22% of all deaths for AAPI. Now, this is actually a really big problem for us because the Asian American population is the fastest growing population in the United States. And so our population is expected to double by 2050. And so this presents a really big public health problem for us. And so, and actually, I'm sorry, it says cardiovascular disease is second only to cancer, but actually now I think cancer is second to heart disease. So heart disease actually is the #1 cause of death still. But it's kind of interesting because when we delve into this a little bit more, This is actually one of the things where a lot of people say, like, well, for Asian Americans, it's not that bad compared to other populations, right? So compared to Caucasian populations, compared to African American populations, compared to Hispanic populations. But I think this missed a lot of the nuanced data and understanding of this. So, while it is true that the prevalence for cardiovascular disease, CVD is cardiovascular disease, is lower for Asian Americans compared to whites. The interesting thing, though, is that more Asian Americans die from cardiovascular disease. And as Hong mentioned, at the very beginning, at the top of the program, I mean, she's had some friends who have died from this. And I'm sure that we've all had some personal connections to people who have passed of cardiovascular disease. And it disproportionately affects Asian Americans. The question is why? Similarly, stroke is the same thing. So the prevalence for strokes is when you have a blood clot to the brain or a bleed in the brain. It's lower for Asian Americans compared to whites, but proportionally more Asian Americans die of strokes or have an earlier onset of strokes. And so the question is why? And what we also know too is that as we actually delve into the different subgroups, it's actually different. So we can't group all of the Asian American subgroups together. So we know, for instance, that cardiovascular mortality is higher in Asian Indian men and women, in Filipino men, and in Japanese men. But we don't really understand why exactly that is. This may have to do with some of the risk factors, and I'll get into that in just a little bit in some more subsequent slides. But I thought that maybe a good place to start, after talking about the epidemiology, is just to ask, well, what is cardiovascular disease? Because this can be sort of a tricky question. Cardiovascular diseases encompasses a whole host of different subdiseases that have to do with the heart. The one we think about most, though, is coronary artery disease, which is a blockage of blood in the arteries that feed our heart. And these blockages occur from the accumulation of plaque that occurs in the epicardial arteries. So those are the arteries that sit on top of the heart. And these arteries feed blood and oxygen to the heart muscle itself, because after all, the heart is just a muscle that just beats. Plaque forms for a variety of different reasons, and we'll get to some of the risk factors in a little bit. But over time, with age and with the exposure of multiple risk factors like smoking, age, bad diets, high cholesterol foods, sedentary lifestyle, these blockages can increase. And over time, it can actually decrease the amount of blood that goes through, or you may have a heart attack. And what a heart attack is that this plaque here ruptures, and that causes an acute blood clot, which causes what we call a myocardial infarction or a heart attack. And then what you see here is that part of that heart muscle dies because not enough blood is going through. And that's what we call a heart attack. And you guys are probably familiar with the heart attacks, but that's pathophysiologically what happens in the heart with a heart attack. Now, there could be some other things that encompasses heart disease. And you may have heard of some of these things like congestive heart failure, irregular heart rhythms like atrial fibrillation or ventricular tachycardia. With COVID, you might have heard of the pericarditis and the myocarditis. You might have heard about some valvular heart problems. Those all kind of fill in the area of heart disease. But for the purposes of this talk, we just want to focus on blockages in the arteries of the heart, otherwise known as coronary artery disease. So what affects heart health? There's a variety of things that can affect it. So the thing on the top there is hyperglycemia or diabetes. Diabetes, we'll talk a little bit more in our population because diabetes actually specifically affects our population differently. But diabetes is considered the same as having coronary artery disease. And that was based on a study in 2005 from the Journal of the American College of Cardiology that looked at the incidence of heart disease in patients with diabetics. And they found that it was the same as patients who had heart disease that had recurrent blockages. So for all intents and purposes, having diabetes is considered the same thing as having heart disease. But there's other risk factors, right? So high blood pressure, we talked about, smoking, high cholesterol, if you have a family history, if you have a sedentary lifestyle and don't exercise much, obesity, we'll talk a little bit more because the distribution of obesity in Asians is different from other people, and that might be more atherogenic, meaning that it might actually cause more atherosclerosis or blockages in the arteries to the heart. And so those are some of the things that cause heart disease. And here again, it's just another depiction of this. One thing in the bottom right here, I don't know if you can see this, but stress. So psychosocial factors can cause a lot of this. And so these type A personalities can cause high blood pressure, which can cause more coronary events. It can also cause dysrhythmias, which are irregular heart rhythms that could cause myocardial events as well too. But this is just another way of looking at it. Gender may also play a role here too. So coronary artery disease happens more commonly in males, but for women who are postmenopausal their rates of coronary artery disease actually equals that of men after menopause. And one of the things that we'll talk about a little later on is how the symptoms for women may differ from that of men as well too. And so actually that might be a good time to talk about it now. So what are some of the signs of a heart attack? You guys have probably heard about some of these things. You know, one of the things that people say is that they have chest pain. A lot of times they'll actually like clench their fist and they'll put it right here on their chest, or they'll say like, it feels like an elephant is sitting on my chest. Whenever we hear that, someone complains of chest pain right in the middle of their chest, associated with shortness of breath, is worse with exertion, better with rest. They might get sweaty with it. They might have some arm pain or jaw pain. They might have some nausea or vomiting. They might complain of dizziness or passing out. Those are things that we get really, really worried about, that could represent a heart attack. Some of these things, though, are a little more subtle. So a good example is my dad. My dad is a Chinese-American gentleman. I think when he was in his late 50s, early 60s, he just started slowing down. But he would still play tennis every day. He would still go swimming. You know, as I mentioned, we're from Hawaii originally, so he would still go to the beach and go swimming every day. But he just couldn't do as much. And this was a very subtle thing, a very surreptitious, it happened over time. And he just happened to mention to his doctor. And he just said, you know, I just feel a little more weak, a little more tired. I don't have quite the same energy that I used to have. And so that led his doctor to do some tests. And the short of it is he ended up having a 99% blockage in the main artery that runs down the front of his heart. We call that the widowmaker, because typically it happens to men. They have a huge blockage in the main artery that feeds their heart, and it kills them and it makes widows because it affects mostly men for that. But that was something where it wasn't an acute thing where all of a sudden he became sweaty, he became sick and nauseous, he complained of severe chest pain. It was something that happened over time, and it was very subtle findings. But this is the reason why we actually want to bring awareness to some of these signs and symptoms, just so people might be a little more cognizant of it, and they can actually bring it to the attention of their doctors. Now, we talked about women. Women, we know, don't have the same symptoms as guys do. And in fact, for women, we say any discomfort, anything that they complain about, we say anywhere from the chest, from their nipple to the navel, any symptom also, they could complain of upper stomach pain, you know, flank pain, chest pain. We have to be concerned that could represent heart disease. And in that case, we say we have to have a high index of suspicion, meaning that we have to suspect heart disease if they complain of any symptoms. And we have to have a low index for testing, meaning that, you know, that when we pull the trigger to do more testing is a very low threshold, because we have to be more cognizant for women because they don't have typical symptoms. And the last category that I'll talk about is diabetics, because a lot of our populations has diabetes. In fact, a third of all Ohioans have diabetes or prediabetes. Now, for diabetes, you don't have the same symptoms as well, too. In fact, a lot of times you might not have any chest pain. It might present with more non-specific findings like shortness of breath or swelling in their legs or fatigue. And so for diabetics, kind of like women, any signs or symptoms, you have to have a suspicion that this could represent heart disease. Let's see here. Uh-oh. It looks like my slides, oh, there we go. Okay, sorry about that. My slides just kind of froze for a little bit. So if you do have some signs or symptoms that's concerning for heart disease, what do you do next? And the best thing to do is to talk to your doctor about it, because there's a lot of things that could masquerade or mimic heart disease, you know, like acid reflux. We see it very commonly. Anxiety, we see it commonly. You know, musculoskeletal pain could actually masquerade as heart disease. And so your doctor will help differentiate if it is your heart or if it could be something else. Now, if you do have a lot of those risk factors that we talked about, like high blood pressure, a history of smoking, a history of high cholesterol, an extensive family history, a sedentary lifestyle, you know, if you might be a little overweight, that might tend to lean them more closely to doing further tests for your heart. And what I tried to depict on this slide here is some of the tests that they may do for your heart. So have you guys heard of the stress test? You know, like what stress tests are? Yeah, it's pretty common. A stress test is a screening test for heart disease. So it's a non-invasive test, meaning that it's not a test where we actually go inside your body. But what we do is we try to detect heart disease from imaging, like an EKG or an echocardiogram. An echocardiogram is an ultrasound of your chest. We can do nuclear imaging, which is depicted on the right upper slide of the slide, It's where we actually give a radioisotope, we inject into your arm, and then we actually look at the difference in the isotope that's emitted, the gamma rays that are emitted, and that gives us an indication of if you might have blockages. On the bottom, the middle bottom, it's actually a newer modality that we have that you actually may hear of. Your doctor or your cardiologist may actually even recommend this, but this is a cardiac MRI. This is something that actually has really kind of blown up in the last, gosh, about 15 or 20 years. In fact, when I was at Duke University, the cardiac MRIs became really, really popular because they've been so helpful, but they give us even better sensitivity and specificity to evaluate heart disease. But there's a whole host of different tests. When I explain this to my cardiology fellows and my medical students, I say it's actually kind of like a whole Chinese menu of stuff, where you look at different ways to stress the heart, and then you look at different ways to image the heart, and you put those together, and that gives you a very good screening idea if you might have heart disease. Now, if you do have heart disease, then it actually leads to further invasive testing, and that's a heart catheterization, where we actually go inside your body through an artery in your wrist or an artery in your leg. We thread a catheter to the arteries that feed your heart. We squirt dye in those arteries, and then we take X-ray pictures to see if you might have blockages. If you do, we can open it up right then and there with balloons and stents. That's called the stenting. Or if it's not amenable to fixing with balloons and stents, then we might need to do open heart surgery and do a bypass. In that case, what they do is they actually harvest some veins from your leg, and they use it to bypass those arteries in your heart, supplying a new conduit to parts of your heart that wasn't getting enough blood, thus bypassing the arteries that are blocked. So that's how we actually work up the most, that's how we typically work up heart disease and how we treat it. One thing that comes up though, and I just want to talk about this because some people might have heard about these, it's the coronary calcium score, and also the cardiac CT or the cardiac CT angiogram. The coronary calcium score is something that's a little more in vogue. And what it does is it uses just a CAT scan of your chest to detect and measure the amount of calcium in the arteries of your heart. And that gives us an idea of if you might need more testing. So for someone, and there might be a lot of people on this call right now, they don't have any symptoms at all. No symptoms, but you might want to get a better sense of, if you're at risk of developing coronary artery disease. Then one thing you could do is get a coronary calcium score that might then guide your doctor on if you should be on other medicines like statins to help prevent the further progression of coronary artery disease. Now, if you do have chest pain symptoms, then the other thing that's becoming really popular is this CCTA or cardiac CT angiography. What this is basically like a heart cath, but you don't have to go inside your body. And so for this, it actually lights up the arteries. And so in this case, I don't know if you can see this here, but these are the arteries that feed the heart. And this can tell us if you might have blockages. So this is sort of like a heart cath without actually the risks of going inside your body. And there's a lot of, I was talking with Hong yesterday about this, but there's a lot of societies like the European Society that's actually recommending this now as a first line of testing for people that have symptoms of heart disease. And so this was some of the treatments that I was talking about. I mentioned that if we did find blockages, then we can open it up with balloons and stents. And this is how this looks like. So on the upper left here, this first picture is a balloon that they put into the blocked artery. They deploy the balloon and it smushes the plaque to the side. And then what they do is we deploy a stent in there, and the stent causes a scaffolding to keep the artery open. The really cool thing is that these stents, they actually have embedded in them little drugs. And these drugs are eluted over the course of a year to actually help keep the artery open, to help reduce the reformation of plaques. The one at the bottom here, this is actually a picture of open heart surgery for the bypass grafts. And what we do is we literally crack open the chest. This is rib splitters that they use to hold the ribs open. And then they harvest the veins from the legs and they use that to bypass the blocked arteries. And this is called the coronary artery bypass grafting, colloquially known as a CABG, C-A-B-G. So you might hear that term passed around a little bit. So those are the treatments for heart disease. And we talked about some of the risks. And so the question is, well, what can you do to prevent heart disease? And a lot of this goes back to those risk factors that we talked about earlier. Unfortunately, a lot of it is genetically determined. So I'll tell you, I have patients here that are morbidly obese. They weigh 300 pounds. Their blood pressures are 200s over 100. Some of them have literally started smoking at the age of 8 years old. And I kid you not, they started smoking at 8. So you would think that they'd be a setup for heart disease, yet they do just fine. And it's because of their genetic background. Conversely, I know that we all have stories of people who are really healthy. They exercise, they eat healthy, and then they die of a heart attack. And in that case, again, it's their genetic predisposition to heart disease. And that's the reason why for us, it's really important to actually elicit a good family history. And so if they say, and I've had family members that told me this, they'll say like, all the males in my family, my dad, my uncles, my grandfather, they all had heart attacks at the age of 50. That's very, very telling for us. And we know that they have a genetic predisposition to heart disease. And so we actually really better do everything that we can to reduce the risk. Exercise is important. And maybe if we have time, we can talk a little bit more about exercise for Asian Americans, because exercise actually isn't as, well, exercise is helpful, but for Asians, we have to work harder at it to actually to derive the benefit of it. We were kind of joking around earlier. It's kind of like everything with Asian Americans, we have to work harder, harder to get the jobs, to get into colleges, but it's also with exercise too. A healthy diet. And perhaps if we have some time later on, I think there actually was a question about diet. We can go into the specifics of a diet because there's lots of questions about, is it a Mediterranean diet? Is it a low carb diet, a high protein diet? What about the Asian diet? How does that work? So maybe we can talk about that a little later on. But good blood pressure control. So blood pressure is actually one of the leading non-communicable causes of death worldwide now. And so blood pressure, we want to actually make sure that's down. It wasn't that long ago that we thought high blood pressure was good. But we now know that high blood pressure can contribute to coronary artery disease and also a whole bunch of other problems like eye problems, kidney problems, lung problems. And so getting your blood pressures under control is really, really important, either through a low sodium diet, so cutting out the fast foods, the restaurant foods, the processed foods, taking blood pressure medicines, and exercise all reduces blood pressures. And similarly, reducing cholesterol is the same thing. A lot of it is exogenous factors like the foods that we eat, the exercise that we may or may not do. But a lot of it we know is actually genetically determined. So if people have familial hypercholesterolemia, they have extraordinarily high levels of bad cholesterol, which is just genetic. We can reduce that level a lot with the plethora of really good medicines that we have nowadays to reduce cholesterol. But reducing your cholesterol, knowing your cholesterol, reducing it is going to be really, really important to make sure that you prevent heart disease. Smoking, smoking, a lot of us have actually, or a lot of people have stopped smoking, but I'll show you some data a little later on that smoking does still happen in our Asian American populations. So cutting smoking and cutting alcohol is really important. And also weight loss. Weight loss is really, really important. There's a whole host of new medicines out there that help with weight loss. You may have heard of them. A lot of the celebrities are actually getting on these medicines to lose weight, which probably isn't recommended because it's usually just for people that really have weight problems. But there are a lot of really good agents that can help you lose weight nowadays. This was actually one thing I did want to talk about obesity and diabetes. And just to make the point again, that it's different and we can't really group all of the subgroups, Asian subgroups together. So in this case, the columns are Chinese, Filipino, Asian Americans, Japanese, Vietnamese, Koreans, and other, right? The blue lines are if you're obese. The red lines are if you're, the blue lines are if you're overweight. The red lines if you're obese. The green lines are the amount of people who have diabetes. And the purple lines are the people that actually have heart disease. And what you see here is that it highly varies, right? So for Chinese, they actually have lower rates of obesity, but maybe slightly higher rates of heart disease. But for Filipinos, they have higher rates of obesity, but lower rates of heart disease. And when you compare one group to the other, you see that it highly varies. And so this is, again, just to make the point that we can't group all the Asian American people together. And we have to have a little better understanding of some of the risk factors that we talked about with obesity and diabetes. One of the things that we are learning, though, is that for Asian Americans, the distribution of fat in your body is different. And this kind of depicts just some of the different distributions. For Asian Americans, what we find is that it's actually mostly the second and the third group. So it's mostly central adiposity. So mostly the fat around the bellies. It's not necessarily, when people say that they have a pair distribution or an AAPI distribution, the pair distribution is it's mostly around the buttocks and the thighs and the legs. So for Asian Americans, it happens mostly centrally around the belly. Turns out the central adiposity is actually the most atherogenic, meaning that people that have most of their fat around their belly, they have the higher tendency to form clots or form blockages in the arteries to their heart. And so that's something that differentiates Asian Americans to the rest of the groups. Tobacco use, so on average, about 10% of Asian Americans are smokers. Those numbers are declining, but again, it depends on the different subpopulations. So Korean Americans have a higher rate of smoking than the Japanese or Asians. Chinese is actually somewhere in between. for that, but across the board, we say cutting down tobacco use is going to be very, very important. And one thing I want to talk about is diabetes, because diabetes affects Asian Americans differently. So, right now, the American Diabetes Association says that for anyone, if their BMI or their body mass index is above 25, you should get screened for diabetes. And the body mass index is just a measure that we use that looks at your weight and your body composition, your height and your weight to calculate your BMI or your body mass index. It's sort of it's a measure that we use mostly for research purposes, but we've incorporated into the clinical realm. And they say if your BMI is above 25, then you should be screened for diabetes. What we now know, though, is that for Asians, it's different. And for Asians, if their BMI is 23 or higher, that's when we should start screening, because diabetes happens at a lower BMI for Asians, and that can put us at a higher risk. Most people do not know this. And I'll tell you, most doctors don't know this. So we actually tried to actually have this educational program across Ohio to educate doctors that they should be thinking of screening their Asian American patients for diabetes if their BMI is 23 or above. And this is a program called Screen at 23. It's a nationwide program that we're trying to implement. But what I want to tell you guys is, for you, if you know what your BMI is, and you can go online and calculate your BMI, it just asks for your height and your weight, and it'll calculate your BMI. If your BMI is 23 or above, you should talk with your doctor about doing a screening for diabetes or prediabetes. Prediabetes is a stage before diabetes. And the other thing that I'll tell you too, and this is again a difference for Asian Americans, is that the test for diabetes is different from others. Most people look at the hemoglobin A1C, which is a measure of what your average blood sugars were for the previous 3 months. But for Asians, the most sensitive measure is what's called the oral glucose tolerance test. The oral glucose tolerance test, or OGTT. And what that does is it actually looks at your blood sugar levels at baseline, and then they actually give you a sugar bolus. They give you an IV with sugar in it. They wait 2 hours, and then they see how well your body's able to process the sugar. And for Asian Americans, that's actually the best way to determine if you're at risk for diabetes. Again, most providers, most doctors don't know about that. So this is something that you can advocate for yourself with your doctor to say, gosh, my BMI is 23, so screen me now for diabetes. And if you do screen me, use the oral glucose tolerance test, or the OGTT, as the best way to determine if Asian Americans, as myself as an Asian American, is at risk for diabetes. And these are just my last slides here. So this is more of a global perspective, and then we can take some questions. But so in general, Asian Americans have more barriers for preventative care and treatments, and that affects their heart. And there's a number of reasons why. So higher prescription drug coverage, an incomplete understanding of disease. A lot of times providers won't take the time to explain to us what's going on, particularly if there's a language barrier. There's also just some cultural differences. And so one of the things that we're doing with the Ohio Asian American Health Coalition is to do training on cultural sensitivities, to let providers know about some of the cultural sensitivities they need to be aware of when they talk with us about health problems, particularly heart disease, or even just like COVID or other kinds of things. A lot of us, particularly the older generations, might have a wariness to Western medicine, which could be helpful, but could also be detrimental if that actually prohibits them from getting on statins or blood pressure medicines. And also, a lot of the times, we don't even know about the preventative services that are out there. And so some of the things that we've been doing is having health fairs that go into the individual communities just to actually do health screenings. But this is what happens because of this health disparity. I just want to leave you with this. I think this is my last slide, is that the treatment for Asian Americans for cardiovascular disease is different, and we're adversely affected. So on average, Asian Americans had the second longest times for treatments of acute heart attacks. Second longest times. So people are getting their heart attacks treated much faster than Asian Americans. And there's a lot of reasons for that, some of which I actually covered in the previous slide. But also, part of this is also us. We had a 20 to 30% lower adjusted odds ratio of using emergency medical services when we have stroke-like symptoms. So I think what this actually tells us is that, we have to address this from two folds. One is from within. So each of us has to take responsibility for preventative health services, making sure our blood pressures and cholesterol are under control. If we are having symptoms, we really have to advocate for ourselves. We have to tell our doctors, we have to call the ambulance, we have to tell them, I'm worried that I'm having a heart problem. And this is what you should do. Screen me for diabetes at an earlier BMI, use the appropriate tests, make sure that My blood pressure is under good control. So from a personal basis, we have to do that. On the other hand, from more of a global health perspective, we have to do more of what's pictured here on the right. So this is actually a health fair that we actually did in one of the Lao temples, where we went there. We had a whole host of preventative screenings, and we had hundreds of people show up there. But I think that if we did this from a community health perspective, reaching out into our Asian American communities, making sure that they have preventative health services available, that would dramatically reduce the incidence and prevalence of cardiovascular disease. So I think that was it. I'm sorry I ran a little long. So I'm so sorry about that, but I hope that provided a good background. And maybe now, would that be a good time, Hong, to open it up to questions?
Yeah, definitely. In fact, as since that we have so many people register, we received a lot of questions ahead of time already. So maybe let's go over some of the questions that's queued up already. And thank you so much for all those, very informative, very useful information. I think there are a lot of things that we might not be aware of before, but now we'll be more kind of aware, such as the BMI at 23. I think that's something that I don't know about. So during your presentation, you did mention about the diet, and then or the such as right now when we look in the commercial or the airway, we see all these diet options. They are just like a fashion. One day you'll hear about the keto diet, the other day Mediterranean, and then the vegan, intermittent fasting, low carb and low fat, and etc. So such as the low carb, for us, we are Asians and we eat rice, we eat noodle. If low carb, that means we shouldn't be eating them. Then what do we eat? So what is your opinion on how to choose the correct diet and what to watch out for in our diet?
So, the data for that shows that a low carbohydrate diet and a high protein diet does help you lose more weight. And actually, as your heart changes from a more of a carbohydrate-based metabolism to more of a ketone-based metabolism, it does make the heart function a little more efficient. The data does show that keto diets are very effective in weight loss. The only problem, though, is in maintaining that. And so people always cheat. And when you cheat, that's actually when the wheels come off the bus and actually it gets really, really bad. But a low carbohydrate diet, on average is actually very helpful for weight loss. There's varieties of the low carbohydrate diet. So like the Atkins diet, the keto diet, they're all variations on a theme for that. The South Beach diet is a different variation where they actually allow some healthy carbs like vegetables. The Atkins, or actually the original Atkins was just only meat, no vegetables, nothing, none of that kind of stuff. The modified Atkins is more akin to the South Beach diet, which actually says that some vegetables are good. And the Mediterranean diet is actually really good. So the Mediterranean diet is more like healthy fats, like olive oil. They actually advocate fruits and vegetables and legumes, like beans and that kind of stuff. And that's actually been shown to actually be very helpful in reducing cardiovascular risk. The caveat with all of this, though, is that you have to maintain the diet. What we see is that people will lose a lot of weight with bad diets, as you're mentioning, but then they rebound, they gain weight, and they do this yo-yo effect. And that's what we don't want. That's actually when cardiac events happen. It's actually when you're yo-yoing back and forth. And you actually want to have a steady diet, and with time, that can actually lose weight over time. So the key is how do you actually have a diet that you can maintain? Now, for Asian Americans, it's tough because our diets are very based in rice. I love rice, and this is something that's genetic. And so I see this in my kids. They just have an affinity to rice and noodles. So the question is do we eschew the diet that's inherent to our culture, or is there a way that we can actually work with it? George King is an endocrinologist. He's the head of the Harvard Joslin Center of Diabetes, and I worked with George. In fact, he and I actually had done a conference together in 2018. It was a National Diabetes Coalition conference, and he actually talks about that, and it's about the Asian diet. And the Asian diet does incorporate rice, and what he maintains, and he actually has a study that came out where he actually looked at the diet in rural China. And they actually found that if you actually maintain a diet akin to what they have in rural China, as opposed to the diets that we have now, which is more fast food based, processed food based, you can actually lose more weight if you have a diet that's healthy fats, lean cuts of meat like pork and chicken and lean beef, and you also do incorporate rice with that as well too. So that's just a long way to say that the diet that we have as Asians can be healthy. What we have to do is we have to cut out a lot of the American influences. So things like the McDonald's, the Wendy's, the Kentucky Fried Chickens, that kind of stuff. If we stick to our true indigenous diets, which is lots of fruits and vegetables, lightly pan fried things, baked things, steamed things, that's actually very helpful to us. And we don't have to give up necessarily the rice and the noodles and the bao and the buns. I hope that answered the question. If there's any other questions.
That's awesome. That's awesome. So now I can feel very safe because I do, besides the rice and noodle, I do eat a lot of vegetable and lean meat. So good.
But it's interesting because when they looked at obesity rates in China, it was actually very low. But the obesity rates in China started to skyrocket once KFC started going into the country, and McDonald's and Burger King. That's actually when their obesity rates start to increase. And so that's what we have to do here, is avoid the fast foods, the restaurant foods, the processed foods, all the bad stuff.
Yeah, for sure. Very true. Very true. So I think there is also one audience asked the same question, which is our question number 2, is that you did mention that in the presentation is that Asian, we need to work out harder. And again, as I shared that one of my friend, he had a heart attack during the exercise and passed away. So then, how do we know that that we are exercising too hard? When do we stop? How do we reduce the risk?
If it's okay, can I share my screen again? Because I actually have some slides here that I want to show you. Oops, let's see. Can you guys see these?
Yes.
Yeah, so exercise is actually really interesting. And so this is a slide that comes from the CDC, and it talks about exercise rates, for different ethnicities. And what we see here is that Asians are actually pretty good at exercise, maybe not as good as Caucasian Americans, maybe a little better than, Blacks or Hispanics, maybe not quite as good, or maybe on par as American Indians. But what we do know, though, is that the effect of exercise may be a little less for Asian Americans compared to Caucasians. And so this takes a look at the different categories, which is just, how active they are. But what they do is they actually take a look at the effect of exercise in lowering your blood sugar or your risk of diabetes. And our risk is not lowered quite as much with exercise compared to Caucasians. So this just tells us that we have to exercise a little bit more to reduce our cardiovascular risk. And I'll stop sharing this. So we should be exercising. The question is when are we exercising too much?
Too much.
Yeah, in general, that's usually not a concern for us because in general, people don't exercise quite as much. So then currently the recommendations are at least 30 minutes, 5 days a week. And the 30 minutes or any type of cardiovascular exercise. So even if it's just gentle walking, so just, walking at a leisurely pace for 30 minutes, it does not have to be continuous. It can be 5 minutes in the morning, 5 minutes before lunch, 5 minutes after lunch, 5 minutes in the afternoon, 5 minutes after dinner, to make a total of 30 minutes. That's the minimal amount because most Americans don't even achieve the minimal amount. For a lot of Asian Americans, we're a lot more active. Some of us are, they'll play tennis, they'll go swimming, and that's absolutely fine. In fact, we actually want you to exercise as much as you can. Exercising too much is actually not that much of a problem. It becomes a problem if you talk about like these ultra marathoners or people that push themselves so much. That's typically not a problem. But we do say that if you're exercising and you experience any of those symptoms that I mentioned, so chest pain, shortness of breath, nausea, you find that you just can't exercise as much as you used to. Like maybe before you could, run up 2 flights of stairs in the house without a problem. And now you notice, oh my gosh, I'm getting more short of breath after 1 flight. That's when we'd say you should talk with your doctor about that. So anything at all. And it might be, a very subtle thing. So like my dad, he was still playing tennis and swimming in the ocean, but he just noticed that he wasn't able to quite do as much as he used to. And that's when he actually saw his doctor, and his doctor very astutely said, well, let's check out your heart, and found that he had a 99% blockage in his left anterior descending artery, the widowmaker. So you have to be very aware of your body and your symptoms. If you notice any change, you just can't exercise as much, like walking down to the end of the driveway to get the mail used to be simple, but now you start to get more short of breath. You have to let your doctor know about that.
That is great advice. So we need to be very mindful of our own body. And then if we notice anything is not right, check with the doctor first, right?
Yeah. And one thing I'll say too is that men are really, really bad about this. The data is actually quite clear that women are very, very helpful. They'll notice if their husband, if their parents have any sort of medical change, and they're the ones to follow up on that. In fact, there's actually really good data that men tend to live longer if they're married, but the opposite isn't true. Women don't live longer if they're married. so men derive the most benefit from being married because the women are more attuned to that. The one thing, though, is that women tend to be more concerned about everyone else, that they forsake their own symptoms and their own medical needs. And so a lot of times they might be having symptoms, but they're so busy taking care of their kids, taking care of their parents, taking care of the household, that they actually don't follow up on their symptoms and they don't see the doctor. And so one thing I will say, though, is that women need to be more cognizant of it, and they need to advocate for themselves instead of thinking so much about everyone else.
That is very true. Yeah, well, let's all remind all the lovely ladies around us to be more mindful of their own health than what they are doing now. So,
Yep.
Dr. Lam, there are a couple of questions related to COVID vaccine that was sent in earlier, such as I think the main question is that does the COVID vaccine increase the heart health issues?
Yeah.
And then if they do, how do we deal with the health issue after taking the vaccine?
So the vaccines are safe. They're very, very safe. In fact, the data is out that if you take the vaccine, there always are a chance of side effects with it, but the chances of having bad heart side effects with the vaccine, either pericarditis or myocarditis or blood clots, is 0.00005. Whereas if you actually get COVID, your chances of having bad cardiac complications is 15,000 times greater. And so it's absolutely clear that it's safer to get the vaccine than to take your chances getting COVID. I could actually talk for another 2 hours of all of the deaths of my patients that I've seen with COVID, all of the tragic stories that I've had to deal with over the past 3 years, 2.5 years now. All of the people who have died, it's just been crazy. But the one thing I do want to emphasize is that the vaccine is very, very safe, very effective. A lot of people say that they don't want to do the vaccine because it hasn't been studied. That is actually not true. The technology that made the vaccines has been around for decades, and is very, very safe. COVID, on the other hand, if you get COVID, you have higher rates of death, higher rates of blood clots. So blood clots in your lungs called pulmonary embolisms, blood clots in your heart, the same blood clots that can cause heart attacks. And we've seen the rates of pulmonary embolisms and death from pulmonary embolisms or blood clots in your heart skyrocket over the past couple of years, and our rates of heart attack skyrocket. The other thing that we've seen, and we're dealing with this now, is that if you've had COVID and you might have survived your bout of COVID, we are now seeing the long-term effects of COVID. You might have heard of some of them. So like the long COVID syndrome that happens with your lungs, and you get short of breath for up to 2 years afterwards. For the heart, you could actually develop atrial fibrillation, which is an irregular beating of your heart. And that actually puts you at a higher risk for strokes because you could form blood clots inside the chambers of your heart that can then travel up to your brain to cause a stroke. Those blood clots could travel to your gut, your fingers, your toes, cause blockages of blood there, and that could be very, very dangerous. And COVID also causes higher rates of myocarditis or pericarditis, which is an inflammation of the heart muscle itself or the sac that surrounds the heart. And that can cause chest pain. It can cause the accumulation of fluid. It could cause death if there's a whole bunch of fluid that accumulates around it, something called a big pericardial effusion or tamponade. And we've been seeing a ton of those now. In fact, the cardiologists are saying that we have never seen this high levels of heart failure, of heart attacks, of atrial fibrillation, and of myocarditis and pericarditis ever, but it's all because of COVID. I do see one of the questions in the chat has to do with heart failure. And this kind of relates to COVID too, because COVID does cause heart failure. But for heart failure, that's when the heart doesn't squeeze very well. And so either there's two types, if the heart doesn't squeeze very well, or if the heart doesn't relax well. So remember, when the heart beats, there's two components. There's the squeeze, when it squeezes blood to the rest of your body. And then there's relaxation when the heart fills with blood again. And heart failure could be either a problem with the squeeze or the problem with the relaxation. One of the things now, this has been a renaissance for heart failure because we've had a number of really, really effective medicines that have just come out in the past 7 years. I know that in here, they mentioned Entresto, which is very good. That came in 2015 with the Paradigm HF trial that showed a 15% relative risk reduction in cardiovascular death and rehospitalization. But more recently, other classes of drugs like SGLT2 inhibitors like Jardiance or Farxiga has been very, very helpful for heart failure for both types. The heart failure with a reduced ejection fraction, but also the heart failure with a preserved ejection fraction, the relaxation. And the kicker is that you don't even have to have diabetes to have that benefit. That class of medicine is a diabetes medicine originally, but you don't even have to have diabetes to have that benefit. So if you do have any form of heart failure, make sure you talk to your cardiologist, because there is a bunch of new medicines out there that have dramatically reduced death and reduced rehospitalizations for heart failure.
Okay,
So I'm sorry, that was a long-winded answer to your question.
that is really useful information. I think we are getting to 8 o'clock very quickly. So the another question that a couple of people ask is about supplements. What supplements do you recommend? How about Q10N? What do you think for the regular people, if relatively healthy, should they be taking anything?
Yeah, so supplements are always a thing. We are always looking for the shortcut, the secret to longevity. There are no shortcuts. The best way to actually prolong your life is a healthy diet. So cutting out fatty foods, fried foods, salty foods, processed foods, and exercise. That's the best way. The supplements, a lot of people say like, well, what if I just took more vitamin E? Well, we now know that actually taking excess amounts of vitamin E can actually be detrimental. Coenzyme Q10 is something that a lot of people have thought that might help. It was interesting. I actually tell the story a lot to my patients because I have a lot of patients that come in on coenzyme Q10. And actually, I was at a conference at the Mayo Clinic. Gosh, this is about 7 or 8 years ago now. And we were talking about coenzyme Q10. And my point was, actually, it doesn't make any sense how it would work, because if you guys all think back to your 10th grade biochemistry class, and I know that for some people it might be a while, but in your biochemistry class, remember how the cell works and the energy production of the cell is in the mitochondria, and the mitochondria produces ATP, adenosine triphosphate, and that's actually the powerhouse of the cell. The way that's produced is in the electron transport chain within the mitochondria. Coenzyme Q10 is in the very last step of the electron transport chain within the mitochondria. So in other words, for coenzyme Q10 to work, is that you take it, it has to get absorbed by your stomach, it has to get into the bloodstream. From the bloodstream, it has to go into an individual cell. From the individual cell, it has to get into a specific organelle, the mitochondria. And then in the mitochondria, it has to get into a specific last step in the electron transport chain in order to work. That's not how it works. So the coenzyme Q10 does not work that way. The reason why some people derive a benefit is because of the placebo effect. Remember, the placebo effect works a third of the time. So a third of the time, people will say they have a benefit, yet it's just a placebo. The interesting thing that when I was at the Mayo Clinic, we had a long conversation about this. And what the other cardiologists were saying was that, well, even though we know it doesn't work as people say it does, but a third of the time it works because of the placebo, let's just have people keep taking it, because a third of the time it allows people to take the medicines that they need to take, like their statins, like their cholesterol lowering medicines. But in regards to other supplements, there's not really, the data for that actually is very variable. And a lot of that is because it's not regulated. So back when I was at the NIH, we did a study on melatonin. And the problem though is that the melatonin, that's a lot of these supplements that are sold at the drugstores, is that it's not regulated. So the actual amount of melatonin or the active compound is very different. A great example is fish oil. So some of you may be on fish oil, because fish oil has been said to reduce heart disease, reduces atrial fibrillation. At higher quantities, at like 4 grams per day, it could reduce your triglycerides, which is a bad form of cholesterol. What we now know, though, is that the fish oil that's sold over the counter is actually a dimer of 2 different kinds of fish oil: DHA, deoxyhexachlorotic acid, and EPA. And I can't remember what the EPA stands for. Eicosapentaethyl. And so there's these 2 forms of fish oil. It turns out it's the EPA that's important and not the DHA. In fact, if you have the DHA in it, then it could actually negate the effects of the EPA, the eicosapentaethyl. And so these supplements are not pure, they're not regulated, and therefore the beneficial effects, if there are any, could be highly variable. So in general, we don't recommend supplements. We recommend the tried and true things, which is the medicines that your doctor might recommend for lowering your blood pressures or lowering your cholesterol, for your diabetes, but most importantly, lifestyle modifications, which is exercise, eating healthy, avoiding tobacco and alcohol, all of that stuff.
Awesome. I guess in the future, I can stop buying supplements now that I heard you say that. Okay, one last question. We are at the 8 hour. I think for some of the people, if they have a family history or they are more prone to maybe heart issues, and they want to have an emergency kit with them, what should they pack in that kit?
Well, by the time it gets to the emergency, it's probably too late. But in the emergency kit, having aspirin is a good idea. But the problem with aspirin is that sometimes there's times when we would want to give aspirin, like if you're having a heart attack, but other times if you're having a stroke, we might not want to give aspirin depending on the kind of stroke that you have. I've had questions about should people have defibrillators at home? The chances of that happening or being of use is actually pretty low. And so they've done studies looking at the cost effectiveness of it, and it's actually not that cost effective. Time and time again, the best thing to do, instead of having a rescue kit or instead of having a rescue defibrillator, is all the preventative things that we talked about. So things like the heart healthy diets, the exercise. If you do all that, then you could actually prevent the bad things from happening. The thing with the acute and part of those kits, the preventative kits, are things like your blood pressure, having a blood pressure cuff, and monitoring your blood pressure at home. And so, when we monitor your blood pressures, what we say is, monitor your blood pressures the same time every day. If you just take your blood pressures randomly throughout the day, your blood pressures will vary. So if you're running in from outside, your blood pressures may be up. If you're, talking with someone and you get into a heated argument, your blood pressures may be up. If you're watching TV and you're watching an action movie or scary movie, your blood pressures may be up. And so we actually recommend checking your blood pressures the same time every day, sitting for 5 minutes, resting quietly, and both feet flat on the ground, your back well supported, and a blood pressure cuff that goes around your upper arm instead of your wrist, because that gives a more accurate reading of your blood pressures. And then also keeping a close eye on your blood sugars, if you're diabetic or pre-diabetic, and your cholesterol levels.
That is awesome. Thank you so much. Thank you for spending the time with us tonight. So right now, I would like to pass the control of the meeting to Mr. Vincent Wang, who is the president and chair of AACO. Vincent.
Thank you, Dr. Lam, for the great presentation and also patient answering our audience's questions. Those are very helpful. And we have recorded the webinar today, and we will clean up the recording and share with everybody once we finish editing the video. And thanks, Hong, for organizing this event. And I can see a lot of people were still asking questions. Dr. Lam, do you mind if we have more questions? Can we compile them and share with you at a later time if you have some leisure time?
Sure,
to help
absolutely.
answer those questions?
Oh, I'd be
Okay.
happy to do that.
Okay, thank you so much. And also Dr. Lam not only spoke to us about heart disease, and also he's a respected community leader, helped us host the candidate forum in the last few years as well. And that kind of brings us back to one of our core missions. We want to educate, engage, and empower our community members to getting involved in community service, getting involved in politics, civic engagement. And so one of our pillar programs is our public service internship program. We host about 20 to 30 interns across Ohio, from Cincinnati, Columbus, and Cleveland. We train the including high school seniors, freshmen, and freshmen from college, not freshmen from high school. We have high school seniors and some juniors, and also college students interned with our collaborating public service offices, such as state legislature, county offices, and also we also recommend eligible students who has strong leadership to members of Congress as well. And currently, our internship application is open on our website. It is at AACOhio.org. And so we welcome all the parents to share the internship application information to everyone who is interested. And so we provide the training to the young students, help them understand how the government works, help them polish their communication skills and the leadership skills, so they are ready to work in a real life environment, work with members of the assembly offices, such as senators, representatives, and also we have students working for the Cincinnati mayor and also county auditor and so forth. It's a great opportunity. Hopefully, everybody can log on to our website to check it out, and encourage your students to participate. And also we have other events coming up as well. with the election coming, the primary in Ohio general election, we're going to roll out a series of webinars and also in-person events. Please check our website and also our Facebook and WeChat group as well. And if you need to get into our groups, contact us at info@aacohio.org or AACO@aacohio.org. Thank you so much, everyone. Have a good night. Thank you again, Dr. Lam.
Oh, you're welcome. Thank you for having me. And please let anyone know if they have any other questions. I'd be happy to answer them.
Yeah, we'll
Okay,
collect all the
great.
questions, Dr. Len, and then share with you once you provide the answer. We'll put them in a WeChat article and share with the community. So really
actually,
appreciate the help.
Do you mind if I just make one quick clarification?
Yes, please.
So one thing that I want to say is that, all supplements are not bad. In fact, I was at the NIH when they launched the Office of Alternative Medicine. And so when I grew up, we actually, my family practiced things like acupuncture, and we had things like shark's fin, to help with diseases. A lot of Western medicine didn't really accept that because they didn't really understand how Eastern medicine worked. And it actually took the NIH to actually understand how Eastern medicine worked through a Western medicine lens to actually find that it's effective. So my point with supplements is that supplements aren't effective, but it's the type of supplements that it is, because as I was mentioning, like over-the-counter stuff, it's heterogeneous, like the dimer with the fish oil. So there could be some supplements that could be very helpful, but just over-the-counter things you have to be very, very careful about because you don't know exactly the purity of that. And a lot of the things that we did, so we now know how acupuncture works, right? Through the release of endorphins, but it was explained through a Western lens, a Western medical lens. And actually, I just have a really quick story that I'll tell you. So when I was in college, I rode crew, and when I was in crew, I would keep passing out with some of the heavier workouts. So at the Yale Haven Hospital, they put me through a battery of tests, 2 days, where they hooked me up to respirators. They had me on machines that were measuring my CO2 max and my lactic acid thing and all of that. And what they finally diagnosed after 2 days of extensive testing was that I had a low VO2 max. So that Christmas, I go home and I go back to my family's restaurant. In my family's restaurant, one of our employees was a student of Chinese medicine. And he heard about my symptoms and he said, well, let me take a look at your iris. We're studying irisology. And he had no idea what my diagnosis was. He looked in my eyes for 2 minutes and he said, I know exactly what you have. You have a low VO2 max. So he came to the exact same diagnosis through Eastern medicine techniques that it took Western medicine 2 days of extensive testing, probably about $50,000 worth of testing for that. And so my point is that Eastern medicine, Eastern supplements could very well work, but we just have to be careful because we don't know about the purity of those. At least the ones where what you get over here over the counter like GNC or those kinds of things. So I'm sorry, that's the only clarification that I wanted to make.
Thank you, Dr. Lam. And also you mentioned about getting a health screen, right? I know as you are one of the core leaders of the Ohio Asian American Health Coalition, and your organization does free health screen at Asian Festival and other venues. Do those screens help?
Yes, absolutely. So you can come down to the Asian Festival this year. It's the weekend of Memorial Weekend down at the Franklin Conservatory Park area, and we do free screenings, but we also do screenings in your neighborhoods as well. And that's, we work mostly with the specific communities and to set up the health screenings. And you can always approach the Asian American Health Coalition if you want to set up a screening for your specific community as well. One of the big things that we're working on this year is mental health screenings, because we've been finding that particularly with COVID, mental health has been a big issue, and that affects everything, right? It affects your cardiovascular health, but also suicidality. It affects, basically everything. And so we've been doing a lot of mental health screenings as well too.
Right now it's 11 after 8. I guess let's wrap up. And really, thank you so much, Dr. Len, for tonight. And everybody was just so happy with the information. I see so many comments saying that this is super informative. So thank you for the time and thank you for the, the help to the community.
Oh, my pleasure. Thank you guys so much for having me.
Great. Have a good night, everybody.
Thank you, Dr. Lam. Thank you, everyone. Have a good night.